and it will be more like a practice for your exam. So don't what you call, don't be cool and answer what you know. Okay, and be clear and simple. You not to complicate things. Okay, it should help you in the practice. Practicing as is more like a rehearsal for your exam. Okay. Okay. Sir, we'll start with it. Okay. All the best. Can you tell what is the resting membrane potential for a neuron?
Resting membrane potential for a neuron is about 70 millivolt.
Yes, sir.
And there is a process of neuronal depolarization. Firstly, it reaches the threshold potential of minus 55 millivolt by a spontaneous drift. Then there is sodium channels opening, and it reaches the potential of plus 30 millivolt. This process is known as the depolarization. And then the sodium channels close and the potassium channels open, and there is a flux of potassium which causes the depolarization, and the potential is decreased, and in the phase 4 there is hyperpolarization because there is sodium potassium pump which lags behind the ionic potential.
Okay. You said the resting membrane potential is minus 70. How is it maintained?
It is maintained by the potassium channels.
Okay. What is after hyperpolarization?
After hyperpolarization. I don't remember.
Okay, no problem. What are the factors which limit the depolarization process? How the depolarization switches to hyperpolarization?
The membrane may be refractory in absolute refractory period. That is up to part of the depolarization, in which no impulse will cause action potential, will cause a response, and there may be relative refractory period.
Okay. Absolute refractory period, time period is, it's in depolarization or in hyperpolarization. What is the time duration for absolute refractory period?
Till the 1/3 limb of the depolarization, and from there to the zero potential, it's a relative refractory period in which more than a normal stimulus will cause a response.
Can you explain the synaptic transmission? How the structure? Can you basically tell me the structure of synapse and the steps involved in synaptic transmission?
Yes. Neuromuscular junction is the junction between the
synaptic transmission, not neuromuscular junction. Synaptic transmission.
To that is the junction between the neuronal cell and the muscle, innervated muscle cell by the neuron, and these
too much disturbance.
Yeah.
Dear participants, others can mute their. Thank you. Carry on, please.
Muscle cell.
Yeah. You can.
Is stored in the vesicles, neuronal cell, and some of these vesicles are in the deeper part of the neuronal cell, and some are on the periphery. And the are immediately available for the neuronal transport, while the deeper vesicles act as stores. There are acetylcholine receptors on the trunks of the acetylcholine stress in the in the deeper parts,
Hmm.
the postsynaptic junction. So, and there are also presynaptic membrane. When acetylcholine is released by the synaptic vesicles, which which acts as a neurotransmitter and acts on the receptors on the postsynaptic membrane.
Can you tell about, okay, can you tell about postsynaptic potentials? Types of postsynaptic potential and mechanism of postsynaptic potentials?
There may be in-plate postsynaptic potentials, and they because some of the potentials are generated spontaneously by the release of small amounts of acetylcholine vesicles, and which accumulate to form a action
What is
potential.
excitatory postsynaptic potential? How is that? What is the mechanism of excitatory postsynaptic potential?
A spontaneous release of acetylcholine in small amounts from the presynaptic membranes. Because to produce an action potential, about 200 vesicles of acetylcholine are required.
What are the different EEG waves you know of and their frequencies? EEG waves.
EEG waves, not yet, sir.
Okay. Can you explain circle of Willis?
Yes, circle of Willis is an anastomosis between the internal carotid artery and the vertebral artery. Firstly, there is a vertebral artery which combine to form the basilar artery, which form the posterior cerebral artery, which are communicated through the posterior communicating artery to the middle cerebral artery, and internal carotid artery gives rise to anterior cerebral artery, which are communicated by the anterior communicating artery, and this anterior cerebral artery along with middle cerebral artery combined with the posterior cerebral artery.
What is the normal cerebral blood flow?
Yes.
What is the normal cerebral blood flow?
Normal cerebral blood flow is 50 ml per 100 gram per minute.
Okay. How is it regulated?
Normal cerebral blood flow is regulated by the myogenic mechanism that by increasing the radius of the cerebral vessels, the blood flow will increase, and it will lead to increase in the intracranial pressure. And also there is auto-regulation of the cerebral blood flow by between the mean arterial pressures of 60 and 160 mmHg.
That is the first point you have to tell on cerebral blood flow. What is the mean arterial? How it is regulated tightly? What are the factors? Simply. What are the? Just tell the title. What are the things which controls the cerebral blood flow?
Also, it is regulated by the PaO2, partial pressure of oxygen. And below 8 kilopascal, there will be cerebral vasodilation and increase in the cerebral blood flow, which will lead to increase in the intracranial pressure.
What is flow metabolism coupling?
Flow metabolism coupling, auto-regulation is disturbed above the MAC of 1.5 MAC, and there will be increase in the cerebral blood flow, and it will lead to increase intracranial pressure.
What is the autoregulation curve? Can you draw the autoregulation curve?
Autoregulation curve for mean arterial pressure.
Yes. How it is maintained? What is the role of PCO2 in autoregulation?
The PSO2 varies linearly with the cerebral blood flow in the range of 2.7 kilopascal to about 10.5 or 11 kilopascal.
And what the changes in blood flow you can expect for every 1 kilopascal change in PSO2? How much it can increase the cerebral blood flow? If you know, you can tell.
I don't remember exactly what
No
5
problem, no problem. It's 30% cerebral blood flow. Okay. How CSF is produced?
CSF is produced in the ventricles of the brain by the choroid plexus.
What are choroid plexus? How will you explain choroid plexus? What's the choroid plexus?
Choroid plexus are basically white matter in the brain with capillaries which produce the CSF.
What is the amount of CSF? What is the total amount of CSF?
100 to 150 ml CSF.
How much is produced per day?
50 ml.
Can you tell the pathway of CSF?
Yes, CSF is CSF is produced in the third, like right plexus in the third ventricle. Then it comes to the from lateral ventricle to third ventricle by foramen of Monro. Then third ventricle to fourth ventricle by aqueduct of Sylvius. And from fourth ventricle, there is a median pathway, median foramen, and there are two lateral foramens. The median is foramen of Magendie, and the laterals are foramen of Lasca. And the CSF then goes to the spinal cord or the cerebrum, and then observed by the dural venous sinuses according to the pressure gradient between the CSF pressure and the venous pressure, and observed by the arachnoid villi.
What is the normal intracranial tension, intracranial pressure? Normal value.
Intracranial pressure is up to 15 mmHg, and from 15 to 20 mmHg there is intracranial hypertension, and there 20 to 45 mmHg there is focal ischemia, and above 45 mmHg it is global ischemia.
Why intracranial tension is so important? Why we need to maintain it?
The skull is a rigid structure; its volume is fixed, and there are three.
What is Monro-Kelly doctrine?
I'm coming to that. There are three things in the skull, that is blood, CSF, and brain tissue. There will be compensation if some amount of any of the things like any blood, CSF, or brain tissue is increased, but after a level it will decompensate. So it will lead to ischemic changes. This is Monro-Kelly doctrine.
How ICT is regulated? When there is a rise, and what are the compensatory? In other words, what are the compensatory mechanisms for raised ICT?
By the
Okay, if the patient, imagine a case, acute trauma, head injury, or some hemorrhage coming for surgery, and you feel, how will you know the patient is having raised ICT?
There are clinical signs, and we can employ the measurements also by devices.
Yes.
Firstly,
clinical, please.
There will be
pupillary. If patient is on table, how will you know if patient is on table, operating table, and how will you know the patient is having raised ICP?
Raised ICP will cause dilatation of the pupils. It will also
pupillary asymmetry. Pupillary
asymmetry will be there. There will be tense brain in some cases.
Before induction. Before induction. Tense brain will be during surgery. Before induction. On table. Any other?
Respiratory changes will be there.
What respiratory changes?
Have
you heard of Cushing triad?
Yeah, it will be hypertension, bradycardia, and increased ICP.
respiratory irregularities. Okay. What are the measures you can take to reduce the ICP? On table.
Firstly,
What are the measures to reduce the ICP?
yeah. Firstly, we will go for a 30-degree head elevation. It will induce the optimal venous drainage to reduce the ICP. Then we can avoid the volatile anesthetics that will increase the ICP.
How it increases the ICT? Volatile anesthetics.
Because they disturb the autoregulation above 1.5 max.
How?
And also cause increase in the cerebral blood flow.
How it increases the cerebral blood flow?
Vasodilation and increasing the.
We already discussed flow metabolism coupling. It increases the CMRO, cerebral metabolic rate. Thereby, the increased metabolism, increased blood flow, increase the ICT.
Then we can also, during the induction of the patient, we will have to keep a more mean arterial pressure, because cerebral perfusion pressure will be mean arterial pressure minus intracranial pressure. So mean arterial pressure of about 80 mmHg is recommended in normal subjects. And also during the induction, we will use opioids to avoid the sympathetic stimulus and the changes in the ICP, like remifentanil we will use. After endotracheal intubation, we will hyperventilate the patient to reduce the CO2. It will reduce the ICP. We will maintain a deep plane of anesthesia so that changes in ICP are avoided.
Any drugs we can give to reduce the ICT?
Yeah, we can generally, after head injury, we can use thiopentone coma to reduce the ICP. Also, the drugs which can reduce.
How thiopentone reduces ICT?
Yes, sir.
How thiopentone reduces ICT? What is the mechanism? At what dose?
The electrical activity in the.
What dose and what is the mechanism?
It reduces the electrical activity in the brain.
Thereby?
Thereby reducing the cerebral blood flow.
What have you heard about transcranial Doppler?
Yes, transcranial.
What does it measure? What does it measure?
It measures the cerebral blood flow generally in the middle cerebral artery, and can give an estimation of the intracranial pressure. Also, to reduce the ICP, we can use drugs like mannitol.
Good.
Then hypotonic saline. Also, there is some controversy about the diuretics like furosemide.
Any other non-invasive method to assess raise the ICT? Do you know of?
It's the key ischemic technique. It is based on fixed principle.
Okay. Very good. It's a theoretically strong answer. Any practically which anyone can use? Measuring non-invasive way of measuring the raised ICT.
Computer tomography, CT scan.
Okay. Bedside, on table.
Optical nerve shooter.
ONSD. ONSD.
Yeah, well, someone answered it.
Yeah.
Your name, Aditya. It was an excellent session. You are very spontaneous. Yeah, of course, certain questions, certain answers request some clarity, but you are very spontaneous, which is very helpful. Will be very helpful in the exam. My advice would be, your answer should be pinpoint and clear. Clear to the point. What the question asked related to that answer. If you don't know, or if you are a little bit confused, you can easily switch over to the next questions. For this diagram and all, when I attended the exam, it was online exam, like what we are doing now. But in-person exams, better to practice in this topic. What we have discussed is your circle of Willis, and action potential curve, and ICT graphs. All these are very important. Practice with measurement. So this labeling and all is important. As you told, this resting membrane potential is -70 and peak potential is -30. All this has to be important.
Yeah.
So you have done well. So is there anyone volunteering for the next session?
May I continue?
Hello? Yes? You want to continue the next section?
Yes, I can. If you
You
say.
can. Very good. Okay, then we can move on to next session is of muscle relaxants.
Yeah.
Can you classify muscle relaxants?
Muscle relaxants can be classified according to chemically what they are made of: amino steroid and benzyl isoquinones. Amino steroids include rocuronium, vicuronium, pancuronium, while the benzyl isoquinones include atracurium, cisatracurium, mivacurium. Then they can be also classified as short acting and long acting. Like the short acting is mivacurium and the long acting is pancuronium.
Mechanism of blockade? Can you explain the mechanism of neuromuscular blockade?
Mechanism of blockade like depolarizing and non-depolarizing. Depolarizing includes succinylcholine and the non-depolarizing includes benzyl isoquinones and amino steroids.
What is depolarizing block?
In depolarizing block, the major neuromuscular relaxant is succinylcholine, which causes a competitive blockage of the acetylcholine receptors and lead to persistent depolarization and further muscle relaxation.
Why it is called depolarization block?
Because it depolarizes the muscle membrane neuromuscular junction.
What are the clinical features of depolarizing block?
There will be reduced twitch height equally in the neuromuscular monitoring train of 4.
Clinical?
Clinically, what succinylcholine you want to ask, sir?
Depolarizing block, yeah.
It will lead to increase in the intraocular pressure. Arrhythmias like due to hyperkalemia, it increases the potassium concentration by 0.5 millimole per liter transiently. Also, it leads to myalgia. Then it increases to the intracranial pressure. It increases.
Phase 1 block.
What
is phase 1 block? Phase 1 block.
Phase 1 block. Is due to succinylcholine, in which there is a reduced twitch, equal reduction in twitch height in the neuromuscular monitoring train of 4, and it can be reversed by it cannot be reversed by giving the acetylcholinesterase inhibitors like neostigmine.
How structurally acetylcholine and succinylcholine related?
Acetylcholine is made up of acetic acid and choline, and acetyl-CoA and choline. The choline is absorbed from the dietary intake, and acetyl-CoA is made in the mitochondria.
What is phase 2 block?
Phase 2 block.
When it occurs?
Phase 2 block occurs after repeated administration of the succinylcholine, and it can be reversed by giving anticholinesterases.
By any other condition, when your phase 2 block can occur? What is choline apnea?
Sex apnea or succinylcholine apnea is caused due to atypical pseudoplasma cholinestasis, and there are various types of genes encoding for them. EU is normal, and then EA, ES, and EI. And it is assessed by the Debouquin number. And higher the Debouquin number, higher is the activity of the enzyme, Debouquin number and fluoride resistance.
How you can assess the activity of cholinesterase enzyme? How you can assess?
By Debouquin number.
It's qualitative and quantitative. Quantitative, the levels. Qualitative, Debouquin number, and any other thing?
Fluoride resistance.
Fluoride number. Good. Why it is called pseudocholinesterase? If pseudocholinesterase is there, something is called true cholinesterase. What is true cholinesterase?
There is it does not metabolize the acetylcholine as the acetylcholinesterases, and
It's a normal value of pseudocholinesterase. Normal value.
I don't remember.
Okay. What is the treatment for choline apnea? How will you treat?
For choline apnea, we make the we maintain the anesthesia and keep the patient on the ventilator, maintaining the proper oxygenation and the ventilation till the succinylcholine apnea waves off and the respiratory.
What are the acquired causes of choline apnea?
Yes, sir.
Any acquired causes of cholinesterase deficiency? Rather than
Cardiac failure, renal failure, thyrotoxicosis.
any common cause you can relate to?
Genetic polymorphism.
Pregnancy.
Pregnancy is a more common. Liver, kidney diseases, hypothyroidism, etc. Now, can you tell about non-depressing muscle blockade mechanism?
Non-depolarizing muscle relaxants acts on the myoneural junction, neuromuscular junction, and they block the acetylcholine receptors by forming the block the acetylcholine receptors.
One simple keyword here is competitive inhibition. Simple. To tell competitive blockade of acetylcholine is simple, straight to the point. See, in this exam, sorry to interrupt. See, this sort of exam, they are not expecting you to know everything. If you have seen that, I am switching over to question again and again. That means I want to ask you maximum questions in the minimum available time. But thing is, I was expecting that key answer from you. Once you answer that, I will switch over to next. If I'm waiting, I'm still waiting for the key answer. That is the clue. That's what. See, in examiners, they won't show any expression that whether we are answering right or wrong, they won't show you in their face. No, they simply see at you. The moment they see with the question, that means either you have answered right or you are not answering right. They just expect that keyword. If you answer that keyword, the question switches over. So while answering to the point, again I'm saying to the point, have that keyword in your mind. Okay. Then the more questions and more the conversation happens, so more chance that you will clear the exam. So non-depressive muscle action we are discussing, no? What are the factors that can prolong the muscle blockage?
Acidosis, hypothermia, hypoxia, hypercarbia.
Most commonly.
Acidosis, metabolic acidosis.
drugs, any volatile agents?
Local anesthetics can prolong, volatile anesthetics can prolong,
Which volatile agents more sensitive?
tetracyclines can prolong.
Which volatile agent is more sensitive for muscle relaxant?
Yes,
Non-depressant. Which volatile anesthetic agent will prolong the muscle relaxant effect maximum?
sevoflurane.
Desflurane. Second one is sevoflurane. Desflurane is the most. And
Also
the
prolongs.
yeah. Any other drugs you know of?
Botulinum toxins, then tetanus,
Antibiotics.
aminoglycosides,
Any other clinically useful adjunct and adjuvant anesthetic agent which can prolong muscle blockade? It's more like a adjuvant analgesic, used as more on adjuvant analysis.
Magnesium.
Very good. Good answer. Good answer. Tell me about Sogamadex.
Sogamadex is a selective relaxant binding agent.
What is the structure chemically? It is chemically
Modified gamma cyclodextrin.
It's an oligosaccharide.
Oligosaccharides. And it has a lipophilic core and hydrophilic periphery. It encapsulates the rocuronium so that acetylcholine can act on the neuromuscular junction, and it also encapsulates vicuronium, but it is less potent for the vicuronium.
Why it is not effective against atracurium?
Can you repeat, sir?
Atracurium. Why it is not effective against say benzyl compounds? Why it is specifically binds to aminosteroid? As you said, acronym and vicuronium. Why it is not effective against other your classic muscle laxants? How it differs from your classic reversal agent, say your anticholinesterase? What is the major advantages of having the Sogamadex as a reversal agent?
Yes, because we give the anticholinesterase, then we have to add the anticholinergics along with it to avoid the muscarinic side effects. And so Sogamadex can be given individually, and drug error can be minimized as we are not giving the second drug prevent with it. And also there will be less chances of recruitization with Sogamadex.
And irrespective of the level of blockade or stage of neuromuscular blockade, you can reverse. That is the first and foremost point. What is the dose?
Dose is from 2 mg per kg to 16 mg per kg. And multiple vials are maybe used.
What is ED95? ED95. How is it useful in calculating the dose of muscle laxant? ED95.
ED95 effective dose 95, which will be able to reverse the neuromuscular blockade in about 95% of the cases.
How it ED25 is related to intubating dose of a muscle laxant? What is the relation? It's usually 2 to 3 times of the ED95 is your intubating dose. What is cisatracurium? What is the specific benefit of cisatracurium?
Cisatracurium has benefit that it causes less histamine release, and there are less chances of hypotension and bronchospasm with cisatracurium. But the onset of action will take more time, and it will not be as rapid as the atracurium. And also there will be less ludenosine formation from cisatracurium.
Can be given as infusion.
Can be given as infusion.
Tell me about malignant hyperthermia.
Malignant hyperthermia is basically there is sudden increase in temperature during it is autosomal dominant disorder, which may occur intraoperatively, where it can be life threatening due to sudden, there may be
How
clinical
you know?
features.
How you know the patient has developed it?
There will be sudden first sign may be the unexplained tachycardia, but there may be increase in levels of EtCO2 in the capnometer or capnography. There will be hyperthermia, and it will, with the tachycardia, gradually the oxygen saturation may decrease, and also there may be hypotension. It will also affect the kidney, and there will be acute kidney injury and metabolic acidosis.
During
The
surgery, a patient, you are anesthetize the patient. I am not forget about the agents or drugs. Patient suddenly has, as you said, tachycardia, raised ECO2 and temperature, raised temperature. What will you do?
we will maintain, we go with the ABC approach, airway, breathing, and circulation.
Okay.
First, we will stop all the volatile agents. We will administer the 100% oxygen. We will hand ventilate the patient.
Disconnect
Also,
the circuits.
connect the tubes and hand
Remove the
ventilate,
circuits.
the patient. And we will employ the aggressive cooling measures. We will also correct the hypoxia if they have 100% acidosis, and also look for the urine output. And if there are acute kidney injury, we will collect. We will also ask the surgeon to stop and inform ask for senior help. And instead the ICU, we will look for the dantrolene sodium, which works for the malignant hyperthermia and acts by excitation.
You told there is a rise in temperature. What will you do for it?
We can cooling pads, we can use cold saline, we can use, we can give cold water, a cold saline in Riles tube and the Foley's catheter. And we can use the dantrolene sodium to treat the malignant hyperthermia, which works by excitation, contraction, uncoupling. It's a skeletal muscle relaxant.
What is tetanic stimulation?
Tetanic stimulation or repeated stimulation to elicit post-tetanic response. Repeated stimulus are generally given for 5 seconds, and which may lead to the mobilization of the acetylcholine to elicit
What is the idea of tetanic stimulation? What you are going to achieve by tetanic stimulation? What is the mechanism behind it? Why it is required and where it is required?
In the cases of deep neuromuscular blockade,
what will see? What you will see? How will you interpret?
It may be used or in the to.
What is double burst stimulation?
Two responses are given 1500 milliseconds apart to elicit a response. In the cases of very less neuromuscular blockade or light neuromuscular
residual blockade.
Yes.
To know about residual blockade.
Residual blockade.
So in pharmacology questions, if they ask any drug, have it in mind to tell in a order way. First, what is the chemical structure? How it is present in liquid form or crystal? What is the dose, standard dose? Any specific pharmacokinetic property. I won't, you need not to remember all the elimination time, T of all these things, but there will be some specific pharmacokinetic property. Say this dantrolene that comes and prepared with mannitol. That's just a specific thing. So like that, the key point. Then what are their actions? Then what are their side effects? What are the contraindications? If you need not to tell as a title, but in this sequence, if you tell, it will be easy for you to answer and not to miss. And also the examiner will assess you as you know everything about the drug. So pharmacology, you study the drugs in this manner so that you can be easy for you. So this session also done excellently, extraordinarily well by you. But still, you have to be a little bit more clear in your answers. That's what I say. It shows you are prepared and you are ready, but still you need some more clarity in your answering. The way you answer, is okay, but the clarity in the answers needs to be, as I told, it's be pinpoint and crisp, and more practice. But the whole idea of this program is for this practice only. More you practice, more you can achieve. So all the best for your exams. Anyone wants to volunteer? Again, we can take one more session for the missed questions. Yeah. I have still more. Some of the questions I have prepared. I can. Anyone volunteering?
Sir, I haven't read, but I can give it a try.
Yeah, please. Yeah, please. Can you explain the nerve action potential? Go.
Yeah, sure, sir.
Yeah.
So shall I draw it or I just
You
narrate
can
it?
tell in this here it is drawing and explaining is will be difficult. Just you can practice. Even there you can draw and yourself you can read out. No problem.
Okay. So the nerve action potential for the mixed nerve fiber, it has a resting membrane potential of minus 70 millivolts, which is because of difference in the permeability of the ions of the resting membrane, and that is more permeable to potassium. So that's why the inside of the cell is more positive as compared to the outside of the cell. And when a stimulus comes, there is change in the permeability of the ions, and the sodium channels open up. And as the stimulus is strong enough, the threshold potential is reached, which is minus 55 millivolts, and it causes more sodium channels to open up in a positive feedback loop system. And then the action potential is generated, which causes the action potential to reach from 0 to plus 35 millivolts. At that time, sodium channels close and potassium channel starts to open, and which causes the repolarization. And this potassium channel ultimately opens up for a longer time than the sodium channel, which causes the resting membrane potential to restore. But when a series of these action potentials are coming over and over again, the ionic balances are disturbed, which is maintained ultimately by the sodium potassium equilibrium.
What is after depolarization?
Pardon, sir?
After depolarization.
So the after depolarizations are the membrane got hyperpolarized as the potassium channels open for a long time. The membrane got hyperpolarized, and then this membrane is again depolarized to the resting membrane. That is for after depolarization, I think. Sorry, but
No problem. What is the size of synaptic cleft?
it's 20 micron.
What is blood-brain barrier?
So blood-brain barrier is basically it's
How it is different from any normal blood capillary, any other place? What is that?
it protects the any substances from plasma to pass into the blood into the brain. So it has it is because of basically the tight junctions and the fenestrated capillaries, choroidal capillaries, and it has got some ionic impermeabilities also to like.
Why we need a tight regulation? Why we need this blood-brain barrier? What is the specific purpose of this blood-brain barrier?
So it protects the brain from the bacteria and the chemical disbalances to occur.
Endogenous and exogenous toxins. You can tell like that.
Yes.
Then. we know all this, most of this ionic balances in the central nervous system has to be tightly regulated. So the ionic concentration should not vary
Yes.
in the CNS to maintain the constant ionic concentration. Second one, to prevent from endogenous toxin, and to avoid transient changes in glucose. We know hypoglycemia is more dangerous to brain.
Yes.
And also protect some of the central neurotransmitter escaping from the central nervous system into the blood flow. So these are the functions of CS. Blood flow, we need a blood-brain barrier. What is the composition of CSF? What are the, I don't want an exact answer. How it differs from plasma?
So the CSF composition, it's like pH is all little bit acidotic as compared to plasma, like range is 7.28 to 7.40. Protein is less, it's around up to 0.45 grams per liter. So the buffering capacity is
Remember
low.
everything. Good. Yeah.
The buffering capacity is low. The glucose is like around 60% of the plasma.
Good.
And also calcium is also low, around 50%.
Good. Good. Yeah.
But the calcium and magnesium is higher than the plasma.
Good.
Sorry, chloride and magnesium is higher than the plasma.
Choroid plexus. What is choroid plexus?
So choroid plexus is it is the capillaries which produces the CSF through the filtration mechanism.
Filtration and as well as secretion.
Yeah, filtration and secretion mechanism.
What is arachnoid villi?
Arachnoid villi are found in the dural sinuses. So these are the projections of the venous sinuses which helps to absorb the CSF in the last.
How the CSF is regulated? Cerebral blood flow. How is the cerebral blood flow is regulated? Regulation of cerebral blood flow.
So the cerebral blood flow regulation is like two theories: the myogenic theory and the metabolite theory. The myogenic theory states that if first of all, it is auto-regulated between the mean arterial pressure range of 50 to 150 millimeters of mercury. If the blood pressure increases, like if the patient gets hypertensive, it causes a vasodilatation. It causes vasoconstriction, the myogenic response, and there is decrease in the cerebral blood flow. Opposite happens if the patient blood pressure falls. In the case of metabolite theories, there are some metabolites like the H+ ions, potassium ions, adenosine. They all causes vasodilatation in cases they increase. And in other then apart, that CO2 and the PCO2 also plays a role in the metabolism in the cerebral blood flow. So for the oxygen, the cerebral blood flow is maintained till the PO2 of 8 kilopascals. If PO2 falls below 8 kilopascals, cerebral blood flow increases. And there is a linear increase in cerebral blood flow in between the range of 3 to 10 kilopascals of PCO2. Beyond that, the cerebral flow increases and decreases.
And how the ICT is regulated?
So,
what is the compensatory
ICT
mechanism, natural compensatory mechanism for ICT?
Yeah. So according to Monro-Kelly doctrine, ICT can be regulated through the three components: the brain component, the brain parenchyma, the blood, and the CSF. Now the brain itself cannot shrink, so the main mechanism is through the CSF. First of all, the CSF gets absorbed in the CSF production is constant. The CSF absorption is increased through the arachnoid villi, and it also shifts to the spinal compartment. Then the increase in the venous outflow through the dural venous sinuses. The venous outflow is increased. These are the two mechanisms natural to compensate for the increased ICT.
What are the ways in which we can reduce ICT? Or in other way, what are the things which we do which can increase ICT?
Which we can increase
I'm
ICT.
asking the reverse question. What are the anesthesia side we will do which might increase ICT?
Yeah. Okay. So again,
there's a reverse question. If you know this, you will avoid this. That's in that way I'm asking.
Yeah. Yeah. So the again we have the three components. We have to maintain the brain parenchyma, the CSF pressure, and the blood volume. So any factors which increases which causes vasodilatation increases the cerebral blood flow, and this increased cerebral blood flow will cause ICP to increase. So we have to maintain the cerebral blood flow. So we have to we can CO2 tension we have to maintain. We have to avoid hypoxia. We have to avoid acidosis. Then in the CSF pressure,
We have to
It's,
avoid
uh,
hypercarbia also.
yeah, as I told that hypocarbia, and we have to hyperventilate the patient. We have to hyperventilate the patient to prevent
Somebody has
increase in
answered.
ICP.
Somebody has answered in the message. Yeah.
Head
Then
low
we
position.
have to keep the head up to prevent increase
That's
in
the
ICP.
first question. First answer you have to tell. Head and
Okay.
elevation. Is the
Then
first and
while
foremost. How it helps?
keeping the,
Okay, how it helps? How head
pardon,
and
sir?
elevation? How head and elevation
Yeah.
helps to
So
reduce?
head and elevation causes the venous return to increase, and that's why it decreases the cerebral blood flow. And while tying the endotracheal tube, we have to make sure that the tie does not causes the venous decrease the venous pressure, does not impinge on the venous system.
Avoid kinking of your neck. Kinking
Yes.
and large veins getting compressed. Okay. Any other thing which, as an anesthetist, we are worried about, which might raise the ICT?
Lighter plane of anesthesia during intubation.
Good. Any other thing? What about PEEP? Whether it will increase?
PEEP, of course, again causes the venous return to decrease, and it causes increased ICP.
Good. And any other thing? Volatile anesthetics?
Yeah, volatile anesthetics causes increased cerebral blood flow through uncoupling the cerebral metabolic rate and cerebral blood flow. That's
What
how
is the
because of vasodilatation.
ideal choice? As you mentioned, volatile anesthetics will cause. Whether we will avoid a volatile anesthetics totally, or we can still give.
We will give volatile anesthetic. Isoflurane is the choice, and we'll keep it below 1 max.
Very good.
Sevoflurane.
Very good. Sevoflurane, anything is okay. Even desflurane is not an issue. But thing is less than 1 max is the first key point. Okay. And what else you can do in treatment side? Okay. What will you give? How you are pushing head up, and you have avoided PEEP, you have avoided volatile agents, or you kept MAP. What else you can give to reduce ICT?
Now we can reduce the shrink the size of the brain, so that we use osmotic diuretic. So we can give
What is the dose of mannitol?
Yeah, mannitol we can give in a dose of 0.25 to 1 grams per kg. Then we can use furosemide in a dose of 0.25 to 1 milligrams per kg.
What is the first and foremost thing you need to the mannitol to be given? What the prerequisite for the mannitol?
For the mannitol to be given, we need that the patient cardiac system, the patient is not in cardiac failure, because it can precipitate the cardiac failure.
Okay, good. Then
the ionic, we have to check the electrolyte balance. We have to check.
The systolic blood pressure should be more than 100, at least 100. And the renal
patient already should not be in hypotension.
Make sure there is a renal perfusion. At least some urine output is happening. These two are the first. Apart from what you said, of course, cardiac thing is important. This three is important before you give mannitol. Okay, Deepak, you are done well. So it was nice.
Thank you, sir.
Okay, your answers were spontaneous, and whatever you answered, you have prepared well. It's good. This is enough for you to clear the exam. Okay. All the best. See you next time. And kindly leave the feedback. This is my first appearance. I may not be that much sound perfect, but I will try to improve on my future classes. So please leave out any sort of feedback, even if it is negative. Thank you so much.
So do we have to give a feedback in a prescribed format, or we can write?
I think it's there in that thing, no, in our website. I think in our Medusis thing. In each class.
Okay, sir.
Okay. Thank you all. Thank you all.
Thank you, sir.
Thank you.
Thank you.